This is A&P Live Studio. I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced healthcare professionals. Today, we're going to tackle a critical paradox, one that every healthcare professional faces. How can the very drugs we use to treat severe pain sometimes make that pain worse? Let's unpack this by starting with a clinical scenario you might see any day in the ER.
So meet Jordan. He's a 20-year-old collegiate soccer player who was prescribed opioids after a knee surgery, but now he's back in the emergency department. His chief complaint is that his pain, this diffuse musculoskeletal pain, is actually getting worse even though he's been increasing his opioid dose. On top of that, he's dealing with severe anxiety, he can't sleep, and he's having intense cravings for his pain medication. He also mentions he's really constipated and feels sedated all the time. Jordan's case really forces us to ask, how did a standard treatment for pain lead to this?
To get to the bottom of that question, we really need to understand the complex relationship between opioid pain modulation and something called the gate control theory. By looking at this from a clinical and a pathophysiological perspective, we can start to piece together exactly what's happening inside Jordan's body.
Here's our roadmap for today. We'll start with Jordan's story, then we'll review the body's own amazing pain control systems. From there, we'll see how opioids hijack that system, what the clinical consequences are, how we diagnose and treat this, and finally, we'll look at the impact on the entire body.
Jordan's story is, unfortunately, a pretty classic trajectory. It begins with an acute, very real need for pain management after an injury, which then slowly evolves into a state of chronic dependence, a state where the medication itself starts to drive the problem.
So, before we can understand what went wrong, we absolutely have to review how the body is supposed to handle pain. It has these really elegant built-in systems, what we call the ascending and descending pathways.
Now, a really foundational concept here is the gate control theory. This was proposed way back in 1965, and it truly revolutionized how we think about pain. It suggests that pain isn't just a simple one-way signal from an injury to your brain. Instead, that signal can be modulated or gated at the level of the spinal cord in a specific area called the substantia gelatinosa.
So, how does this gate work? Well, when you get injured, tiny pain fibers, the A delta and C fibers, start firing. They release excitatory neurotransmitters like substance P and glutamate. This action essentially throws the gate wide open, allowing the pain signal to rush up to the brain. But think about what you do when you bang your elbow. You instinctively rub it, right? That rubbing activates larger fibers called A beta fibers, which sense non-painful touch. These fibers stimulate inhibitory interneurons that then dampen the pain signal, effectively closing the gate.
But it gets even more interesting. This whole modulation system isn't just happening locally at the spinal cord. The brain itself has powerful top-down control over these spinal gates. This descending circuit starts in higher brain centers, which then signal a structure in the midbrain called the periaqueductal gray, or PAG. The PAG then talks to the rostral ventral medial medulla, or RVM, which sends signals all the way back down to that gate in the spinal cord. And what's really crucial here is that this system is bidirectional. It can either turn down the pain signal, that's descending inhibition, or it can actually amplify it, which we call descending facilitation.
Okay, so now that we have that foundation, we can finally understand how opioids work. You see, they don't invent a new process. They hijack the body's own powerful pre-existing pain modulation system.
Our bodies make their own natural opioids, things like endorphins and enkephalins, that act on three main types of receptors: mu, kappa, and delta. Now, the opioid medications we prescribe primarily target that mu receptor, and activating it is what gives you the powerful pain relief and euphoria, but it's also what causes the dangerous side effects like respiratory depression and constipation. The pain-relieving effect of opioids is really a two-pronged attack. First, up in the brainstem, what we call supraspinal, they act on the PAG and RVM to supercharge that descending inhibitory pathway. They're essentially screaming down at the spinal cord to slam the pain gate shut. At the same time, right at the spinal level, they directly block the release of those pain neurotransmitters, substance P and glutamate. It's an incredibly effective one-two punch.
But here's where things start to go wrong with chronic use. The entire nervous system can enter a state of hyperexcitability that we call central sensitization. I like to think of it as someone turning up the volume knob, or the gain, on the whole pain processing system. Things that shouldn't hurt start to hurt. This is a key step in the dangerous transition from acute to chronic pain.
And this brings us right to the heart of Jordan's problem. Prolonged opioid use can lead to this paradoxical condition called opioid-induced hyperalgesia. The very drug meant to treat his pain has, through complex neuroplastic changes, actually made his nervous system more sensitive to pain. And it's so important to understand, this is different from tolerance, where the drug just stops working as well. With hyperalgesia, the fundamental pain threshold itself has been lowered.
So, let's take these complex neurobiological concepts and connect them directly to the signs and symptoms we're seeing in our patient, Jordan.
Let's break down his symptoms. That worsening pain? It's a combination of that opioid-induced hyperalgesia we just talked about and classic tolerance from his opioid receptors downregulating. The constipation he's reporting? That's because mu receptors in the gut's own nervous system are being activated, slowing everything down. The sedation is a direct CNS depressant effect, and the anxiety and cravings? This is where the brain's reward circuits, the mesolimbic pathway, have been rewired. Chronic opioid use creates a dopamine-deficient state, which drives that awful feeling and the intense craving just to feel normal again.
This specific collection of symptoms isn't random. It points us toward a formal diagnosis, and that diagnosis is what guides our entire treatment approach.
A diagnosis of opioid use disorder, or OUD, is based on a specific set of criteria from the DSM-5. Looking at Jordan, he clearly meets several of these. He's taking larger amounts for his worsening pain, he has strong cravings, and he definitely has tolerance. A formal diagnosis only requires meeting 2 of these criteria within a 12-month period.
Now for treatment. The frontline approach is using medications for opioid use disorder, or MOUD. We have 3 main options, and they work very differently. Methadone is a long-acting full agonist. It stabilizes the system and reduces cravings. Buprenorphine is a partial agonist. It binds really tightly to the mu receptor, kicking other opioids off, but it has a ceiling effect on respiratory depression, which makes it safer. And then there's naltrexone, which is an antagonist. It just completely blots the effects of opioids, but the patient has to be fully withdrawn before they can start it.
It's really important to remember that the effects of chronic opioid use go far beyond just the central nervous system and the perception of pain. They truly impact the entire body.
Let's look at a few systems. In the respiratory system, opioids directly suppress the brainstem's drive to breathe. This is the primary cause of death in an overdose. In the endocrine system, they can disrupt the hypothalamic-pituitary-adrenal axis, which can lead to things like hypogonadism. We've talked about the GI system, and in the skeletal system, long-term use is linked to a higher risk of fractures, partly because of the sedation and increased risk of falls.
So let's quickly recap this whole process. We start with a normal, protective pain system. An opioid is introduced as an intervention. Over time, with chronic use, that system becomes dysfunctional, leading to tolerance and hyperalgesia. That dysfunction then manifests as the clinical disease of opioid use disorder. And finally, our treatments, like mood, are specifically designed to stabilize that now dysregulated system.
This all leads us to a final, really important question for the future. We've seen just how deeply intertwined the neural circuits for pain, reward, and emotion are. So thinking ahead, how might we develop therapies that can target these shared pathways to treat both the chronic pain and the opioid use disorder at the same time? This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions. Stay patho-curious and see you next episode.